Okay, let's go ahead and get started. I see people are logging on here, so I'll do a very slow introduction. So we are here today to kick off our second Data Science for Public Health Summit. Today we're starting with our first distinguished lecturer in data science for public health. And it is my honor to introduce Kiros Burhani, who will be introducing our speaker. But for those of you that weren't available, 3 years ago, we hosted our first Data Science Summit right before the pandemic. And we will have an all-day event tomorrow. So if you haven't had a chance to register for that, there's still an opportunity to do so. But again, we're starting off today with our distinguished lecturer. And I will now turn it over to Dr. Burhani, the Chair of Biostatistics, to introduce the speaker.
Thank you very much, Gary, and welcome everyone. I'm Kiros Burhani. I'm Professor and Chair of Biostatistics at Columbia University. I add my warm welcome and best wishes for the Happy New Year to all attendees from Columbia and across the US and the world. It's a great pleasure and honor to introduce today's speaker in our distinguished lecture series in data science, Dr. Sherri Rose. The title of her talk is Algorithmic Bias and Machine Learning in Healthcare. Next slide. Dr. Rose is a professor of health policy and co-director of the Health Policy Data Science Lab at Stanford University. Her research is at the interface of data science and causal inference and is centered around developing and integrating innovative and cutting-edge statistical machine learning approach to improve human health and health equity. Dr. Rose works specifically on risk adjustment, ethical algorithms in healthcare, comparative effectiveness, and health program evaluation. Next slide. Dr. Rose got her Bachelor of Science in Statistics degree in 2005 from the George Washington University and her PhD in Biostatistics in 2011 from the University of California at Berkeley. And then she completed a postdoctoral fellowship in biostatistics that was NSF funded in 2013 at the Johns Hopkins University. Next slide. In a very short period, Dr. Rose has actually been one of the leading scientists and stars in the field of causal inference and data science and its application to health equity, algorithmic fairness, and so on and so forth. And in fact, her work has garnered a lot of awards and recognition. She was elected fellow at American Statistical Association in 2020, and the Mortimer Spiegelman Award from the American Public Health Association, which is given to the most promising scientists under the age of 40 in 2021. And there are many, many additional mid-career awards that she has received in recognition of her trailblazing work. She has been heavily funded in some high-profile funding mechanisms. She's a recipient of the NIH Director's New Innovator Award, and this ran from 2017 to 2022. And she also received the NIH Director's Pioneer Award, which runs from 2022 to 2027. Next slide. Dr. Rose is very widely published and cited, and she's committed to increasing justice, equity, diversity, and inclusion in the mathematical and health sciences. She's a highly sought after speaker in many panels, including the National Academy of Science, Engineering, and Medicine. She has co-authored one of the first books on machine learning and causal inference, which was first published in 2011 and then republished again as second edition in 2018. And she's serving currently as co-editor-in-chief of the journal Biostatistics in recognition of her high status in the field. So it's really a great pleasure to welcome Dr. Rose. And now I will turn the floor to her to give her distinguished lecture in our field.
Thank you for that wonderful introduction. I'm delighted to be presenting this talk on algorithmic bias and machine learning in healthcare for the Data Science and Public Health Distinguished Lecture at Columbia Mailman School of Public Health. My work focuses on developing machine learning algorithms for health economics and outcomes to impact health policy. These algorithms take data and knowledge as inputs into the system with established a priori specified benchmarks. However, Under the hood, there is a methodological grounding in theory while remaining flexible for the large data sets that we use in healthcare and remaining computationally feasible in practice. If it's theoretically optimal, but it takes 3 months to run, that is not something that is likely to be useful for solving real problems in healthcare. I'll add that the machine learning and healthcare literature often is not incorporating the health economics perspective, which is something that my work does. I want to lead with a few quotes that I think helpfully center the kinds of perspectives that influence my work and how I feel we need to be pursuing this type of research. The first is from Barbara Engelhardt. Learning 2 fields takes surprisingly twice as long as learning 1, but it's worth the investment because you get to solve real problems for the first time. We often have computer scientists and statisticians developing algorithms that are not grounded in the real problems they claim to be trying to solve. And conversely, we have health experts who lack the requisite technical background in machine learning using tools they don't fully understand. We need more people who are deeply invested in both in order to make real progress. This doesn't mean that you need to have multiple degrees. You can learn the second field through many avenues, including collaborations augmented by other learning. This is how I, for example, learned what I know in health economics. The second quote is from Rediet Abebe. In both private enterprise and the public sector, research must be reflective of the society that we're serving. There are many elements to this, but one thing to internalize is the problematic nature of homogeneous teams. When you have diverse teams, the questions you ask and answer will be different. How you approach problems and how you solve them will be different. We can get better and broader answers when we include more perspectives, and we are less likely to develop tools that cause harm when we have heterogeneous teams. And this is a core focus of my talk today. The last quote is from Nick Jewell, which is from his book on statistics for epidemiology, which I read in my first year of graduate school. This quote immediately struck me when I was reading it. Behind every data point, there is a human story, there is a family, and there is suffering. We should have tremendous respect for the data that we use in healthcare and public health. These data are not toy examples. The data are not here for our career advancement. We need to do right by the people in our data sources. So now let's talk more about algorithms. We have many existing and new algorithms in healthcare, advances that really hold promise to improve human health and health equity. I define algorithm quite generally as any rule that takes data as an input to return summary outputs. I'm going to start by orienting us on the current state of algorithms in our society. Algorithms are broadly pervasive and they can cause harm across society. For example, Amazon wanted to automate their hiring. They created an algorithm trained on 10 years of hiring data for technical roles. But unfortunately, because most of the hires had been men, the algorithm penalized the word women and all women's colleges. They tried to fix this algorithm, but ultimately ended up abandoning it. In another example, soap dispensers were unable to identify dark skin. The optic sensor to detect hands wasn't designed for darker skin tones. We see similar issues in facial recognition that can lead to dire consequences, where multiple Black men have been arrested in the United States for crimes they did not commit due to faulty facial recognition. Algorithms are also pervasive in healthcare. The data that we have in healthcare includes information about health status, procedures, lab tests, medication, etc. And we'll be discussing issues with these data in a few minutes. Our algorithms can range in complexity from a simple checklist in the emergency room that asks, should we admit this patient, to standard regression analyses aiming to predict length of stay in the hospital, to complex machine learning procedures detecting health conditions using images. The goal here is to yield clinically or policy relevant results to inform decision-making, spanning diagnosis, screening, prediction, and beyond. However, just as algorithms broadly in society can have a negative impact, especially for marginalized groups, this also happens in healthcare. Groups marginalized by the healthcare system include racial and ethnic minorities, disabled individuals, rural communities, people with lower socioeconomic status, and the uninsured, among others. These groups already experience lower life expectancy and poor health outcomes. Algorithms could more frequently be contributing to improving health equity rather than harming it. We've seen, for example, racial bias in an algorithm such that Black patients would not get the care management they needed. There's also an opioid risk algorithm that surveils almost all individuals in the United States who pick up prescriptions, and it can lead to the denial of adequate treatment to those who need it most. So we know that algorithms are pervasive and can cause harm, but how are we combating this issue? Where are we with minimum standards for algorithms in healthcare? There have been various guidelines proposed, including for randomized trials and diagnostic accuracy studies. The FDA in the United States also has recently released final guidance for clinical decision support algorithms, although without an enforcement mechanism. My own work has included several proposed standards and guidelines. These are just some recent examples, though, and uptake, unfortunately, has been weak, with no established minimum standards for general algorithms. This is a problem because it will not be feasible to study most algorithms in randomized trials. Additionally, existing proposed guidelines are insufficiently focused on ethics and fairness, and this is discussed in the recent piece here by Gachoya et al. It's also important to highlight that ethics is woven throughout other areas of research, including conflict of interest reporting and IRB review, but not for the implications of AI tools. So we do this elsewhere, but not here. One of our recent papers included a proposal for an ethical pipeline for machine learning in healthcare, starting from problem selection all the way through to post-deployment considerations. This includes which topics are funded, how are teams constructed, are you using non-representative convenience samples, do you define your outcomes using a variable that is easy to observe in your data, but may have differential mismeasurement. How are we optimizing algorithms? And this part gets most of the attention. And what happens after the algorithm is deployed and implemented? But this is not enough. We need actual requirements. To give just one prior example of the impact that specific requirements can have on the robustness of research, this plot here displays results from a study of the volume of null results in randomized controlled trials that were funded by the National Heart, Lung, and Blood Institute in the United States from 1970 to 2012. You'll see that notably in the year 2000, pre-registration of primary outcomes became required on the website clinicaltrials.gov. Prior to this requirement, they found that 57% of trials demonstrated a significant intervention benefit, compared to only 8% of trials after the requirement to pre-register primary outcomes. So we went from 57% to 8%. This is one compelling result among many regarding the impact of requirements established by entities with power in the research ecosystem. It's going to be a recurring theme. So why do we need minimum standards? There is currently, in my opinion, a proliferation of low quality AI and machine learning research in the healthcare field. And unfortunately, basic standards for published machine learning and AI studies for prediction and classification are pretty lackluster. These studies are unlikely to generalize or be broadly applicable for the improvement of health and health equity. Many of these papers include fundamental issues that have major implications for our trust in the level of evidence that AI provides. This includes basic things like the lack of external samples, no cross-validation, and not considering multiple evaluation metrics, including group fairness metrics for marginalized groups. And I'll talk more about metrics in a moment. Many studies are also conducted with a single year of data and in a single hospital or a medical center. This focus on a limited set of evaluation metrics, with some papers only reporting AUC or R squared, and having the so-called AUC leaderboard that's very popular, it is quite problematic a way to evaluate tools, to decide which classification algorithm is the quote unquote best with a single overall metric that does not capture the totality of the performance of the algorithm. And overall, what I want to stress is that the research does not emphasize or prioritize algorithmic fairness and ethics for AI tools. Now for a bit more on metrics, as I promised, algorithms can have reasonable or excellent measures of AUC and other metrics like false positive rate or positive predictive value, while having near zero measures of true positives. The numbers I have displayed here are not even the most extreme examples that we discovered in our recent paper on this topic. We also saw AUC values in the 90s paired with single-digit true positive rates. And this is not only an issue for rare outcomes or extreme class imbalance for the outcome when we're trying to do those types of prediction classification problems. We also saw these issues when class imbalance for the outcome was 30 or 40%, meaning that these metrics can still be incredibly misleading when the outcome is common, is observed for 30 or 40% of the study sample. A basic standard should be that we need a broad set of overall classification metrics reported that include both discrimination and calibration measures. Additionally, we really need to go beyond all of this and center metrics focused on group fairness, where we also calculate measures for minoritized groups. Common measures of fairness are based on the notion of group fairness, striving for either similarity in predicted outcomes or errors for groups. If this large maroon rectangle on the slide here is our study sample and the individuals in the yellow rectangle are part of our marginalized group, we can calculate metrics inside this yellow rectangle for all individuals in the yellow rectangle, and these can be our group fairness metrics. We can then calculate metrics on the complement group, so everyone who's in the maroon rectangle but outside the yellow one. And these are the individuals who are not part of the marginalized group. These types of fairness measures can help us assess differential performance for marginalized groups. You know, will this tool perform worse among these groups? There are also new algorithms, including some of our prior work, that actually prioritize these metrics jointly with overall fit criteria directly in the optimization problem. And I'll discuss these algorithms and some of our results later in the talk. So what is a path forward for minimum standards in AI health research? The field would benefit tremendously, again, in my opinion, from having standards drafted and adopted by the community where a broad and diverse set of perspectives are incorporated. This would need to be followed critically by buy-in and enforcement from journals and granting agencies. We know that this makes a difference. Having guidelines that are just suggestions does not lead to change. It does not lead to improved rigor, robustness, or fairness. So this may involve additional review criteria and processes for ethics. This idea has been proposed and implemented elsewhere, including at some computer science conferences, albeit without the minimum evaluation standards. It could also include new ethics-centered board members at journals, staff at granting agencies, and ethics reviewers at both. What we need this to lead to is a minimum standard to require ethics, fairness, and health equity considerations for the AI tools. That a tool is robust only if it has been assessed for influencing or exacerbating harms to minoritized groups. Another path is adapting principles from previously proposed social impact statements and working towards specialized implementations that would be necessary for healthcare and medicine and public health. Have the researchers established who is responsible to users if they are harmed by the algorithm? Is the algorithm explainable to users? How accurate is the algorithm? Where again, we would want many measures of accuracy. Is the algorithm auditable by a third party? And this is where I think it gets particularly interesting when we think about paths for public health and healthcare. When I talk about the algorithm being auditable, I mean both the algorithm itself as well as the data. And this is where we may need really creative solutions in healthcare, public health, and medicine, given that we work with really highly sensitive data, and solutions might involve having external auditors being added to data use agreements and IRBs. So this is not without its complexity, but is very important. Because the status quo is far from this. We have many AI publications in healthcare that do not include any real description in the manuscript or the appendix of the underlying architecture for the algorithm, and certainly no open source code. And then lastly on this slide, have the researchers considered the fairness implications of their tools? We discussed some aspects of fairness, and I'll elaborate even further on this in a few slides. So what are the implications here? The potential benefits of such minimum standards, I think, are enormous. This can result in improved generalizability and transportability to diverse populations. It would lead to attenuated claims in the literature regarding readiness for translation and practice. It's hard for me to articulate how many times I've read papers that I would consider at best pilot studies that make really extreme claims in the conclusion that their tool is ready to be launched basically everywhere. We really need to attenuate those claims, as well as better contributing to improving health equity. I also think that there would be fewer weak papers that effectively add nothing to the advancement of science or improvement of public health and functionally only serve to advance the authors' careers. There would just be fewer papers, period, I think. Higher standards, therefore, would reduce waste, wasted resources in both money and time, including the time of reviewers and readers trying to sift through this literature. And to be clear, there are papers of my own that I wrote 10 years ago or even 5 years ago that I wouldn't publish today, or that I would do very differently to be more in line with these minimum standards that I described. I also feel that this would lead to fewer LPUs, or least publishable units. The incentives in academia and other research environments tend to reward the volume of production, sometimes with and sometimes without a focus on quality and depth. This creates the incentive to publish fast, less careful papers that do not align with these minimum standards. And as I tried to highlight earlier, this is just not something that we should be standing behind as a field when the problems that we're trying to solve are just too important. And this is not to confuse LPUs with short, rigorous papers. Short papers can be good and high quality with strong standards. In concert with these minimum standards, we would need buy-in from research and academic communities that supports investigators spending the time necessary to get the most rigorous answers, not the fastest. A similar and related revolution has been going on in open science regarding which types of contributions are valued, and has some overlapping goals with minimum standards for health AI work, including around transparently sharing code and data. So now I'll offer some additional perspectives on ethics and fairness in AI for healthcare research, although these will not be comprehensive, given that we won't be here all day. It's a shorter talk. We'll keep in mind that the goal is to focus on avoiding the perpetuation of harm to marginalized groups, and I'll share ideas towards reducing these harms. There are many questions we can ask when thinking about fairness and ethics in AI research for healthcare. These are just a few and include, who has the power to decide the research question? Who is in the target population? What do the data reflect? We know that our data reflect societal biases, including structural racism and access to care in rural, minority, and low-income communities. Then how will the algorithm be assessed? Are you only considering evaluation metrics and the overall population, or also marginalized groups like we just talked about? And this last question gets a lot of the attention in the algorithmic fairness research, as does building the algorithms themselves. But a key tenet for fairness and ethics in healthcare AI research is centering justice such that benefits, risks, costs, and resources are equitably distributed. And we know that the current equilibrium in our healthcare systems do not do this. So we know that societal bias enters data and algorithms in many ways. Detecting this kind of bias can also be challenging, especially when we don't prioritize collecting the right data. On this slide here, I have an illustration of some of the constructs embedded in the data that we analyze from a wonderful review paper by Mitchell et al. We have the world as it should and could be under a more just equilibrium. What we actually have is the world as it exists, including this societal bias. And then what we analyze in our AI studies are data that are rife with many additional issues like non-representative sampling and measurement error. And this can be especially problematic when these errors are greater for minoritized groups. We can next divide algorithmic fairness methodological work into 3 broad buckets. In the first, we have data transformations where we aim to remove societal bias from the data. Some of my work has focused on this, where we developed methods aimed at reducing disparities in low-income neighborhoods. In healthcare AI applications, there are many different types of electronic health information that might be used for answering targeted scientific research questions. But a key thing is that many times the AI will be secondary to the importance of understanding the processes that generated the data. And this includes the role of social determinants of health, as well as the limitations of each data source. The data encode these biases. In the second phase, in the second bucket, we have the fitting phase. And this is again where the vast majority of the work has occurred, including algorithms that consider adding or removing variables. There's a lot of pros and cons to those choices, potentially having separate formulas for marginalized groups, and varying statistical learning algorithms that prioritize fairness in the loss function. Lastly, post-processing examines how to handle the outputs from the algorithms and could include different thresholds for marginalized groups in classification algorithms. In the last 2 sections of my talk, I've divided them into 2 time horizons because we need to be extremely thoughtful and careful about the tools that we're using. Very much not the motto of move fast and break things. That is how a lot of additional harm has been perpetuated to marginalized groups. Thus, I do have work that is spanning a much longer time horizon of several years or more. And that will be the work that I talk about in this section, the future section. That said, there is also an urgency to work to ameliorate existing harms now. So I will have a now section where I will talk about the projects that we're trying to do in a much shorter time frame to try and address those immediate harms. So we discussed that we have many existing algorithms in healthcare. However, we know that a problem is that even with the most rigorous evaluations of these algorithms, it still leaves questions about the ultimate social impacts that they will have when they're deployed. And we can define social impact as changes that aim to address injustice. The complete social impact of an algorithm can only be fully understood when considering the underlying system that it will influence. And this includes both the short-term and the long-term consequences, as well as the recognition that algorithms can undermine health equity. And my proposed potential solution that I've just begun working on under my new Pioneer Award is to develop the first causal network model for understanding the social impact of algorithms in healthcare before they are deployed, such that we can anticipate and avoid these downstream consequences, especially for marginalized groups. My goal is to fill this gap by leveraging mathematical decision science microsimulation models to create a causal network model of the healthcare system. So if that sounds like a really big challenge, it definitely is, and I'm excited to work on it, but it will be very hard. A high-level overview of the form a causal network model would take includes introducing an algorithm or modifying an existing algorithm. We would see that the algorithm has direct effects on certain nodes, and then indirect effects would then proliferate throughout the system. So building out an accurate system is a really core challenge here. The first class of algorithms that I will build out this causal network model for will be risk adjustment formulas, which have many application areas and aim to adjust for the health of patients by controlling for age, documented sex, and sets of different health conditions. Risk adjustment is one of the most consequential classes of algorithms for social policy, given the millions of lives impacted by them in the United States and around the world. In planned payment formulas, for example, the idea is to redistribute funds conditional on health and encourage competition among insurers based on efficiency and quality, rather than those insurers avoiding high-cost enrollees. And I'll talk more about planned payment risk adjustment in a moment. For hospital quality performance, without risk adjustment, hospitals treating sicker, often lower income populations would be punished for higher rates of adverse outcomes, facing closures of certain programs, even when they provide high quality procedures. So as I noted, this is now a helpful segue into the time horizon of now. A lot of my prior and ongoing work in algorithmic fairness has focused on plan payment risk adjustment. As I described a moment ago, plan payment formulas redistribute funds conditional on health and encourage competition among insurers based on efficiency and quality, rather than those insurers avoiding high cost enrollees. If we think about the average enrollee costing around $6,000 a year, and with over 50 million people in the United States currently enrolled in an insurance program that uses risk adjustment, this is hundreds of billions of dollars. This has massive financial implications. And so I often say to people that, plan payment risk adjustment is not a flashy problem. It is not one that tends to make a lot of headlines, the same way that when we talk about, is AI going to replace radiologists? But this has such a tremendous impact on health outcomes and how we spend money in the healthcare system, and can have a true impact on health equity that I'm really passionate about working on it. And it's a very understudied problem in this space. So to be really concrete, a risk adjustment formula is a regression where we have spending outcome, an input vector of those health variables, and in some formulas also age and documented sex categories. And most of these X variables are binary flags. So they're 0 or 1 variables. So you either have the condition or you don't. Or I should say, you're either coded as having the condition or you don't, because we know that there are going to be errors in those codes. And then we have a coefficient vector that we aim to estimate. To be concrete about bringing together algorithmic fairness and risk adjustment, the typical algorithmic fairness problem has an outcome Y, which we just saw on the previous slide as our spending outcome, and a vector X that includes a protected class or a sensitive attribute A. Earlier in my talk, I discussed that there are many groups marginalized by the healthcare system, including racial and ethnic minorities, disabled individuals, and people living in rural communities, among others. These groups also include individuals who are living with chronic health conditions. So I said the typical algorithmic fairness problem above, and it is true that the typical problem in algorithmic fairness focuses on a single group. But in practical healthcare applications, we usually have multiple groups and potentially intersectional groups. And I'll talk more about that shortly. However, I just want to be clear before I leave this slide that the goal here is to create an estimator for f of x equals y, while ensuring that the function is fair for that protected class A. So in our prior work, we've demonstrated that creating constrained and penalized regressions for continuous outcomes that build fairness constraints directly into the loss function can dramatically improve fairness without large changes in overall fit. These are some of the algorithms I was referencing earlier in my talk when I discussed that we can optimize toward both overall and group level fit. So this paper in biometrics is open access, and our code is freely available. So if you are interested in more of the details on what these loss functions look like, those resources are also, they're online. But to give a high level summary of the results that we found, we had improvements of 98% for group fairness. So we improved undercompensation for these marginalized groups with only about a 4% loss in overall fit, which was actually half a percentage point in R squared. And that's such a small amount that is likely to be tolerable by policymakers. So this was for a single marginalized group defined by a health condition, mental health and substance use disorders in plan payment risk adjustment. And studying mental health and substance use disorders is particularly salient in plan payment, as changes in financing and the organization of mental health care, not new treatment technologies, has made the difference in improving mental health care in the last 50 to 60 years. So we know that how we manage the financing of mental health has major implications for health overall, with 1 in 5 individuals in the United States having a mental health condition. And we know that mental health costs are also substantial. They're number 1 in total costs, and they're number 2 in spending growth. In a different paper in our prior work, we also showed that risk adjustment formulas in the health insurance marketplaces created by the Affordable Care Act recognized only 20% of individuals who have mental health and substance use disorders. So the formula only says 20% of the people who actually have mental health and substance use disorders have them. This is a huge problem because individuals with mental health and substance use disorders can be systematically discriminated against because health insurers can discriminate against groups. Insurers are incentivized to do this for mental health and substance use disorder due to the high costs of these enrollees and this undercompensation that we demonstrated in that prior paper. And plans can discriminate against groups in multiple different ways in changing their benefit design of the plans, such as putting prescription drugs that enrollees use in higher cost tiers. So they can put drugs that would be commonly used by someone with a mental health and substance use disorder in a higher tier in their drug formulary. So this is why developing algorithms like we did in this biometrics paper that nearly eliminate group undercompensation can be so critical for health equity. They can reduce or remove these forms of discrimination. In another paper that we published after the biometrics paper, we extended these findings for multiple marginalized groups in risk adjustment, while also bringing in advances in variable selection and post-processing. So to take a pause and talk about the variable selection component of that and the motivation there, reducing the number of variables in the formula can help prevent gaming by insurers. And so they're trying to make the patients appear sicker without providing better care because they will get higher payments. If you recall the simple formula I showed a few slides back, basically the more X variables that are flagged to 1, again, meaning that the enrollee has that condition, the larger the payment the insurer receives. And the insurers are incentivized to have their enrollees have as many of those flags as possible. Therefore, the more X variables in the formula overall, the more opportunities they have for this type of gaming. And so if we reduce that number of variables, we can potentially reduce that kind of gaming. So our formulas in the second paper reduce the number of variables by 62%. And this is a potentially massive change in insurers' ability to game the system, while also enforcing fairness constraints for 4 different undercompensated marginalized groups defined by chronic health conditions. And a key thing that we were aiming to study here is that we found that prioritizing several marginalized groups in the loss function also led to increased fairness for 88% of the marginalized groups that were not included in the loss function, which is displayed here in the figure in this slide. So this was a really important piece of empirical evidence because we didn't know if prioritizing some marginalized groups, but not others in the loss function, would lead to systematic worsening of fairness for the excluded groups, because it won't ever be realistic to include every marginalized group in the loss function. Instead, we found really promising evidence. We had this increase in fairness for the groups that were not included in the loss function because the money was being redistributed from the overcompensated groups with no conditions, which is an ideal form of redistribution. So despite this finding, we are still concerned about subjective decisions regarding which groups to consider. There's no standardized method for identifying or prioritizing undercompensated groups, given that they are actually rarely considered in formal evaluations. However, there are almost certainly consultants trying to help insurers identify these groups so that those insurers can target them for discrimination, encouraging them not to enroll in their health plans through network and drug formulary changes, like the example that I just gave earlier. We also know that there are complex marginalized groups with intersectional identities that are not defined by a single attribute. In this third paper I'm sharing from the stream of work, we extended the concept of variable importance to group importance to create a new approach for identifying groups defined by multiple attributes. So we built this algorithm using ensembles of trees that were predictive of the residual. As I have displayed here in this plot, we found many previously unidentified complex groups with substantial undercompensation in the risk adjustment formulas, making them targets for discrimination. Undercompensation, you can see here, can be very large, up to $30,000. So that was for the group that had asthma, heart disease, and kidney disease. And undercompensation of $30,000 is large, especially when we consider that the average enrollee costs only $6,000 a year. So here I want to highlight that we used 3 years of data and in 2 different data sources. So the same data that they used to build the marketplace formulas historically, as well as also Medicare data. Harkening back to our discussion of minimum standards, we wanted to study how generalizable and stable our approach would be for identifying complex groups, both over time and across different populations. So we hope that a tool like this can be a path towards more equitable health coverage, but solutions to discrimination may lie outside the formula itself. And this is something that is quite common in the policy space, is that it can't just all be about the algorithms. The solutions may be better addressed through legal remedies. And I will also note that this approach will not be suitable for all applications. And we really have to consider the context before attempting to identify marginalized groups, especially if it may cause harm by collecting additional data or amplifying stigmatizing information. So in other cases, as we saw here, our tool can ameliorate harm and help remedy health inequities. So these are just some recent examples of published projects that we are actively sharing and discussing with policymakers, both in the US and in other countries, where risk adjustment is commonly used, because the goal here is impact in the now, not just papers. And I'll talk more about something else we did with these 3 papers in a few slides. I also wanted to share some of our ongoing now projects that are very focused on having an impact in the near term. It's pretty typical in statistics, machine learning, and public health to only talk about work once it's published. And I feel that sharing new and ongoing work is another way to help establish fruitful collaborations by discovering shared interests and also build bridges over time with policymakers. And so several of these ongoing projects I have are in chronic kidney disease, and I'm really excited about a lot of the directions that we're going. In the first one that I'll talk about, I'm collaborating with Stanford Healthcare, including lead Dr. Michelle Williams, who's an executive director of patient care research and health equity, health policy PhD student Marika Cusick, along with Dr. Monique Lambert, who is manager in innovation and informatics at SHC. So what we're doing at SHC is we're evaluating both retrospectively and prospectively changes to the formulas used in chronic kidney disease care and how these changes impact minoritized racial and ethnic groups. This work involves simultaneous qualitative and quantitative research, and I cannot stress enough how vital the qualitative work has been already. Anyone that uses a healthcare database needs to deeply understand how those values got there. And it's not all in the code book, if there even is a code book, which there often isn't, or it's incomplete. I'm also really excited because we're going to be developing additionally a pilot implementation at Stanford Healthcare of further changes to these formulas, including incorporating fairness constraints like the ones we developed in my prior work. And so this would be a prospective study. This may be a randomized trial. And I'm excited to see where this work goes. And I think it also exemplifies an area where I believe we need to be doing more, studying algorithmic implementation, actual implementation in real world settings. So this is also a good moment to highlight the funding source for this project, which is Stanford Impact Labs. And the work that Stanford Impact Labs funds is focused on projects developing real change with external partners. It was a very rigorous multi-round process to get this funded, with a letter of interest, a full grant proposal, rebuttal, and interview. But this work would not have been funded through traditional processes. There are a lot of uncertainties about how exactly the project will proceed, particularly the pilot implementation that we're going to do in the hospital with the new algorithm. And this is realistic when doing work in partnership with an external organization. And I'm really appreciative that Stanford Impact Labs understands this and supports the project adapting, parts of it potentially failing and pivoting when we need to. And I did want to stress this because there have been many calls to revamp and innovate in how we fund science. And this is incredibly important work to consider for health equity in particular, when we're funding health equity research, to have more flexibility in these studies. I'm also really thrilled to be working on projects with the American Board of Family Medicine, Stanford professor Elise Adams, postdoctoral fellow Lucia Chen, and computer science PhD student Agata Foicharj, not only about making sure our data sources capture more of the population, but also about how and whether we can remove societal bias from data before we even try to use algorithms in the data, as well as developing new generalizable penalty methods. This set of project is funded by the National Library of Medicine, where they had issued a notice of special interest on work in algorithmic fairness. And I'm mentioning these funding sources again, not just to acknowledge them, but also to help illuminate these opportunities, especially for early career scholars whose work may have an overlapping scope. Thinking broadly and sometimes non-traditionally can really help you find great matches. And in the last ongoing and new project that I have on this slide, our research and risk adjustment continues, where I've been working with a PhD student, Marissa Reitzma, visiting students, Meletta Meliz and Stephanie Perez, and Harvard professor Tom McGuire, to improve undercompensation of minoritized racial and ethnic groups in Medicare. And this work follows directly from my prior research in undercompensation and the impact on discrimination in the risk adjustment formulas. The funder here is the Laura and John Arnold Foundation, who were specifically interested in funding risk adjustment research with policy impact. Our deliverables for this work explicitly includes creating a policy brief, summarizing our publications that will be circulated to policymakers. And we've done this type of policy brief before. I said I would come back to those 3 papers on risk adjustment I talked about, and here it is. We recently developed a policy brief in collaboration with Stanford's Institute for Human-Centered AI, summarizing those 3 papers in algorithmic bias and healthcare payment models. And accelerating translation into policy with writing other than academic papers is another way for your work to have an impact. And these briefs reach people who never saw your research paper or couldn't follow it because it contained too much field-specific jargon. So in closing, with algorithmic work everywhere, but especially in health equity, we should always ask why. Why does this algorithm exist? Should this algorithm even exist? Is this an acceptable baseline? I think it's always important to ask why we're doing this work, and who is doing the research matters. I know that I bring my own lived experiences to these projects. I grew up in a tumultuous low-income household facing food insecurity and lack of social support. I was evicted twice as a child. I was also without health insurance for large periods of my childhood. And in college, I was uninsured all 4 years. I know firsthand what it's like to lack access to care. And my life experiences being uninsured and low income are major factors in my passion for health equity research to have real, meaningful, practical relevance. The goal for health equity research should, again, not just be published papers. The problems in health equity are too important. This is not an opportunity, again, for careerism for the already privileged. It's a moral imperative. Research in population health has tremendous potential to influence public health directly and have an impact on health equity. And so I'll end by saying I'm incredibly fortunate to work on these issues with a wonderful multidisciplinary team of trainees with expertise in informatics, medicine, computer science, health policy, and economics. I would like to thank them for their many contributions to our prior and ongoing research. I also want to acknowledge my other funding that helps me advance this kind of work. Previously, this was my NIH Director's New Innovator Award that ended this summer, and now that new work that I discussed on causal network models for understanding the social impact of algorithms is funded by my NIH Director's Pioneer Award. So thank you very much for the invitation to present on these ideas at this event.
Great. Thank you very much, Sherri, for a really fascinating talk. I'm Jeff Goldsmith, an associate professor in the Department of Biostatistics, and it's my pleasure to do the moderation part of this thing. So please, folks, if you're in the audience and you have a question, please go ahead and put that into the Q&A box. Again, I want to thank you, Sherri, for a wonderful talk. I think it was something that touched on the role of data and algorithms and the output of those algorithms in a way that really centered the impact that all of that has on the lives of real people. It was also sort of simultaneously rigorous and accessible. So thank you very much for all of that. One question that I wanted to start off with had to do with a comment that you touched on a couple of different times over the course of your talk, which is that either through the adoption of minimum standards or a recognition of the role that the impact of the work in health equity might have, that requires not just sort of changing cultures and the enforcement of those guidelines on the part of granting agencies or journals, but also a cultural change in the context of something like academia. And I wondered if you could talk a little bit more about that, what you see as either current successes, avenues for future work. What do you think needs to happen, and how do you think we can get there?
Ooh, that is a challenging first question, because making change in academia is difficult because academia isn't one thing. It's this collection of institutions that all have their own cultures. And so I think I've seen examples where, working groups get together and write guidelines for how we should think about the promotion of individuals who are doing team science or open science. And so something like that could be pursued, but I also haven't necessarily seen a huge uptake with those types of efforts. So it can't only be those types of things. And it also can't just be the responsibility of individuals. So all of us especially those of us who are already further along in our careers, especially those of us who have tenure, can have an individual impact when we write letters for promotion, but that's not alone its solution. Unfortunately, I think we would need a systematic effort, a top-down effort from the most powerful people at these institutions to say, this is what we value and this is what we're going to promote, and then demonstrate that over time. So this is not a quick solution, but this is one of those topics where I would love to hear the ideas of other people, and I'm sure there are a lot of potential ways we could go about changing this culture, but it really is going to need the buy-in from a lot of people who already have power in the system.
Great. Thank you very much. One of the things that you mentioned in your talk is that there is the chance that a big improvement for some minoritized groups, it might be acceptable to policymakers, even if it means sort of a loss in overall performance. One of the things that suggests is the need for an ongoing dialogue with policymakers. And one of the questions from the audience is, what happens after your team publishes a paper? Do you present your findings to help policymakers? How do they interpret your findings? What happens next?
That's a great question. It really varies on what type of policy you're working on. So I can just give an example with risk adjustment. I've had the opportunity to speak directly with individuals at CMS and the federal government, where they're actually developing and revising risk adjustment formulas, and they're interested in hearing, what the latest research is and how we can actually incorporate these things in practice, which is why I was really excited to present that second paper where we brought together a number of different innovations that we'd published in previous work, like the variable selection, the post-processing, and the constraints, the fairness constraints, because we were trying to show what happens when you bring all these things together and get closer to being able to deploy them in practice. But that's another reason why I highlighted the policy brief. There are so many different avenues where you're going to get different policymakers' attention. And so establishing personal relationships, writing pieces of work that are not just academic papers, potentially summarizing your academic papers. Sometimes there's opportunities with specific journals, like the journal Health Affairs often has different types of media events where in DC, where you get to summarize your research for a large audience of policymakers. And so there's a kind of, there's not a one size fits all, and I try to go through many different avenues is sort of, I guess, the short answer.
Great. Thank you very much. You mentioned in that response the choice of sort of the kinds of algorithmic fairness constraints that you might impose in a particular analysis. And one of the questions from the audience is that there are lots of different ways that you might propose algorithmic fairness constraints, and they have different properties, they have different effects. How do you choose what's right in a particular context?
That is a great question and a hard question. It's absolutely true that you can consider many different metrics and constraints and penalties, and they might have different impacts on the ultimate outcome that you're trying to understand. And that's why I tried to incorporate this idea of making sure that in the room where decisions are happening, it needs to be a broad set of perspectives. So it shouldn't just be, let's say I'm the person that's developing some particular fairness tools, and I say, here are 3 or 4 different constraints that we could consider. It shouldn't just be somebody doing the technical work. It shouldn't just be somebody who's actually implementing it. We also need to think about incorporating the communities that will be most impacted by this work and try to understand what and centering their concerns, again, throughout this entire pipeline. And something I didn't talk about in this presentation, but having research that really centers community participation is absolutely vital for so much of the work that we're doing in ethical algorithms and AI. And so you could say that this is a non-answer, but that's because there isn't a single right answer in choosing between different metrics. It's not, we can't just look at the results that we get at the end of the study to say this is the right one. And we have to think about the totality of the problem and the communities that will be impacted, and also the other thing that I touched on, which was short-term and long-term consequences. What would be the ultimate social impact of this kind of change, which is not something we see in a table of results when we calculate these metrics.
Great, thank you. A question that has come up a couple of different times has to do with the role of societal bias in the data that one has access to when constructing an algorithm in the first place. And you made reference a couple of times to data transformations that might be useful for removing that kind of societal bias. And I wonder if there's sort of a quick heuristic explanation for how those kinds of transformations might work.
Sure, I can give one example, but this is another area that's quite broad, and it definitely has to be context specific. So in the risk adjustment context, we know that there are patients who are undercompensated and overcompensated. And so the payment that's observed in the data does not necessarily create the correct incentives for insurers to want to provide them care. And so one issue is that some patients can be overcompensated. So the insurer is going to be overcompensated for those enrollees because they have a health condition that is expensive, but they're actually not receiving the care they need. And so by overpaying the insurer for not providing care creates a really bad incentive. It creates no incentive for them to actually provide socially acceptable levels of care. And so one of the ways that you can transform the data or intervene on the data in the risk adjustment context is to actually change the outcome variable so that it would reflect the equilibrium that we'd like to see and actually incentivize them to give the care that they should provide. That's just one example.
Great. No, I think that's a very useful example. Thank you very much. One quick final question. We're approaching the end of the hour. One of the concerns that comes up, especially in the context of auditability, is how is that practical, and what can one do when the data that you're sort of starting with at the outset contains information on human subjects? And so, what do you think are practical suggestions that one might consider when thinking about auditing sensitive data and including that as part of the overall fairness pipeline?
I mentioned in the talk that we could consider things like having external auditors being added to data use agreements and IRBs. So that's something that I think deserves broader discussion. I think there are various criticisms of that as well. It would increase the time that it takes to, validate the study, and there may be reasons why you might not want to have an external auditor come in for the data. And so again, this is another example where I think with data specifically, because there are lots of forms of sensitive data, and there are many examples where we would not want to, building trust with populations, we would not want to share the data beyond the smallest group of people that we could. I think that there's still a lot we can do with transparency for algorithms that we're not doing. And so can we, we need to continue the discussion on both, but what would be the argument against having more transparently shared your algorithm? This is very common with a lot of the deep learning papers where they don't even share basic things about it, let alone, like I mentioned, the code.
Great. Thank you. Thank you very much for an excellent presentation today and for taking the time to answer as many of the questions as we could get to by the end of the hour. I want to remind everybody that this is the beginning of our Public Health and Data Science Summit. We have an exciting day tomorrow, and I hope as many people as possible are able to attend. I want to close, though, by thanking you again, Sherri, for a wonderful, insightful, and thought-provoking talk. Thank you very much for joining us this afternoon.
Thank you for having me.